Hello, my name is Joe Jankovic. I'm a professor of neurology and director of the Parkinson's Disease Center and Movement Disorders Clinic at Baylor College of Medicine in Houston, Texas. The topic that I chose for my presidential perspective lecture is tics and Tourette syndrome, which is a topic that has been of great interest to me for at least 40 years, largely because of its rich phenomenology that spans both motor and sensory, as well as behavioral manifestations. And it is exhibited in children as well as adults. And it's an enigmatic disorder in terms of our understanding of the pathogenesis and pathophysiology, but we have made many advances in terms of treatment, which I will highlight in this lecture. But before I start with the lecture, I'd like to reflect a little bit about my involvement with the Movement Disorder Society. I've been very fortunate to be involved with the Movement Disorder Society right from the beginning. And the notion that there is a need for an umbrella organization for all movement disorders was solidified during this historical meeting in Hamburg, Germany in 1985 during World Congress of Neurology. So here you see the founders of the society, including Dr. Stan Fan, Dr. David Marsden, Professor Tolosa, and Professor Lees, as well as myself. And that meeting, we again discussed the need for an umbrella organization that would include Parkinson's disease as well as other movement disorders. Soon thereafter, the organization was formed, and Dr. Fan became the first president, Dr. Marsden second, and I became the third president of the Movement Disorder Society, which is now named the International Parkinson and Movement Disorder Society. We also recognized early on that there was a need for educational program for practitioners of movement disorders and trainees in movement disorders. And we organized a course, which is now referred to as the Aspen course, 30 years ago. In fact, this year we were supposed to celebrate the 30th anniversary of the Aspen course. Unfortunately, it had to be virtual because of the pandemic. But I just wanted to reflect on the relationship I have developed over the years with Dr. Fan and David Marsden, who unfortunately passed away a few years ago during the Aspen course. And I reflect on some of those early days and my memories of the Aspen course in this article that was just published in the current issue of Moving Along. Tourette syndrome was first described by Gilles de la Tourette, a student of Charcot, in 1885, when he described 9 patients. All of them had jerk-like movements that we now refer to as motor tics. 6 were making sounds, so-called phonic tics. 5 were shouting obscenities, so-called coprolalia. 5 were repeating what other people were saying, so-called echolalia. And 2 were repeating other people's gestures, so-called echopraxia. So these are some of the features that were highlighted by Gilles de la Tourette in his classic paper in 1885. Here's a picture of Gilles de la Tourette listening to his mentor, Charcot, as portrayed in this famous painting that I think most of you have seen. That depicts many of the founders of neurology, including Gilles de la Tourette. Now, as I said, Tourette syndrome is characterized by a rich, phenomenology, motor sensory phenomenology, and I think is a prototype of a movement disorder that really has just about all the features of movement disorders. And I use this aphorism by Sir William Osler to highlight the importance of phenomenology and how understanding of phenomenology can lead us to better understanding of pathophysiology and eventually treatment. In this quotation that we also included in our book that came out of the Aspen course, Sir William Osler said, "To study the phenomena of disease without books is to sail an uncharted sea, while to study books without patience is not to go to sea at all." And I think it really highlights the importance of phenomenology and how this can teach us something about the pathophysiology and eventually lead us to the appropriate diagnosis and treatment. So I think it's appropriate to start with a definition. Tics are defined as sudden, brief, intermittent, repetitive, non-rhythmic, involuntary or semi-voluntary movements or muscle contractions that we refer to as motor tics, or sounds that we refer to as phonic tics. And I prefer the term phonic tic instead of a vocal tic, because not all the sounds that are made by patients with tic are produced by air moving through the vocal cords. So there are many other mechanisms for the abnormal sounds that Tourette patients make. So these tics abruptly interrupt otherwise normal activity or speech. There are many different types of tics, and we could spend a great deal of time discussing the phenomenology of motor and phonic tics, but here I just outline some of the more common forms of tics. We referred to tics either as simple or complex. Among the motor simple tics, clonic jerk-like movements, dystonic more sustained movements, tonic tics consist of isometric contractions that really don't result in any visible movement. Repetitive type coordinated movements are referred to as stereotypic tics. Some patients with Tourette syndrome have blocking tics, where they suddenly stop moving or talking for a period of a few seconds or even minutes. And then there is a group of tics that could be characterized as compulsive tics, where the main driving force behind motor manifestation is underlying compulsion. Phonic tics can also be divided into simple or complex. Simple phonic tics are meaningless sounds like sniffing, throat clearing, grunting. And complex tics are semantically meaningful utterances such as coprolalia. Tics that some could characterize as sensory tics, where the sensation is the primary phenomenon. There are patients with Tourette syndrome who have focal sensations without necessarily having a particular movement, but many of these focal sensations precede the motor tic or vocal tic, and they are referred to as premonitory sensations or urge. They can be localized or generalized. And then there are many studies to suggest that patients with Tourette syndrome have increased sensory sensitivity. Now, I submit to you that most of the patients we see who come to us with Tourette syndrome already have been previously diagnosed, often by their parents rather than by their primary care physicians or pediatricians. Because the parents learn about tics from the internet, so they come to us for a second opinion. So how do we diagnose Tourette syndrome? Well, obviously, we don't have a blood or imaging or any diagnostic test for Tourette syndrome, so we rely on clinical criteria, which were summarized in the DSM-5 diagnostic criteria. They include the presence of both multiple motor and one or more vocal phonic tics present at some time during the illness, although not necessarily concurrently. The tics may wax or wane in frequency, but have persisted for more than a year since the first tic onset. The onset should be before the age of 18, and the disturbance should not be attributable to any other cause, such as certain drugs, like cocaine, for example, or other conditions, including Huntington's disease. And I'll talk about secondary tics later on. And here are just some ICD codes that are used when we see patients with Tourette syndrome. The most common one is F95.2, that is not only just for Tourette disorder, but also Tourette syndrome. And I also want to draw your attention to this provisional tic disorder category, F95.0, which used to be called transient tics of childhood. is now referred to as provisional tic disorder, where tics are present for less than 1 year. So this is the diagnosis that we usually make when we see the patients shortly after the onset of the tics. And then there are unspecified tic disorders. Now, we think of movement disorders as primarily motor disorders, but there are many, many examples where there are sensory aspects to the movement disorder. And we try to highlight some of those aspects in this review article that we published a few years ago. And in this article, we also draw attention to the sensory phenomena in patients with Tourette syndrome, particularly the premonitory urge and other sensory phenomena. Most characteristic features of tics is the presence of the premonitory feeling or sensation. The patient may describe a feeling of discomfort or itch or tension in a local area, and then this is relieved by the motor execution of the tics. But there are some patients who have more of a generalized sensation or urge that is not necessarily localized to the area of the tic. One study, at least, it was found that at least 80% of Tourette patients have enhanced perception of to various sensory stimuli. So this is taken from one of our earlier studies of the premonitory sensory phenomena, highlighting the phenomenology such as urge to move, had to do it, increased tension, and variety of other descriptions that Tourette patients give to describe this premonitory phenomena. And as one would expect, these sensory phenomena are present in the areas of the tics and anatomically correlate with the tics, so they are most frequent in face and head and less frequent in other parts of the body. So in addition to premonitory feelings or sensations, the tics are characterized by brief and intermittent movement or sound. They are repetitive, can be quite stereotypic. They are often suppressible, but the suppression is usually temporary. They are suggestible, so that when I ask a mom, does Johnny have any blinking, Johnny at that point starts having, blinking. It doesn't mean that these movements are functional psychogenic just because they are suppressible or suggestible. They do increase or sometimes decrease with stress. They often increase after stress during relaxation. So children tend to suppress their tics when they are in school, and they often have a rebound in their tics when they return from school. The tics often decrease with distraction and with concentration. So children, for example, who may have fairly severe motor-phonic tics can completely suppress or control the tics when they play video games, for example. One of the characteristic features of tics is their variability. They change in location, intensity, they wax and wane in terms of intensity and frequency. They may remit for even weeks, months, or years. And this is important to keep in mind when we design clinical trials for any kind of therapeutic intervention in tics, because just because a patient improves after taking a new medication, it doesn't mean that the improvement is due to the medication. It could be part of the natural waxing and waning phenomena. There are many misperceptions and misinformation about tics, including that tics disappear during sleep. This is not true, and we and others have shown that tics persist during all stages of sleep. So this is from one of our earlier studies where we did polysomnography in over 30 patients and noted that tics can occur during non-REM sleep. So here's a EMG artifact that corresponds to body jerk vocalization, and even during REM sleep, many patients exhibit tics as demonstrated by the EMG artifact referring to head jerk. So in addition to the presence of tics during essentially all stages of sleep, patients with Tourette syndrome have a variety of other sleep abnormalities. Almost all studies, as we summarized in this article in 2003, have decreased REM sleep. They have increased arousals, and they have a variety of other sleep disturbances, including insomnia, excessive daytime sleepiness, disorders of arousal, and many, many other sleep-related problems. So sleep is often disturbed in majority of patients with Tourette syndrome. Just want to show some phenomenology of tics. Here's an example of blinking. I want to show some cervical tics. This is a tic that I refer to as a whiplash tic, where the patient has this fairly forceful, violent extension of the neck. And you can imagine that if one has this kind of whiplash tic most of the day, that it could potentially have some secondary effect on the spinal column, spinal cord. And there are examples of quadriplegia as a result of these whiplash tics. Here's a more dystonic cervical tic that is often preceded by premonitory sensation. And here's a more clonic cervical tic. Another characteristic tic is the shoulder tic, this rotatory movement of the scapula, again, often preceded by premonitory sensation, is very characteristic, and the stereotypic rotation of the scapula is almost pathognomonic of Tourette. Here's an example of patient with shoulder tic.
Can you, for the camera's on, can you point to the area where you feel that, that sensation? Okay. All right. And then can you turn around for me? Face the wall.
Okay, so again, another example of shoulder tic. And there are limb tics involving both upper and lower extremities. They could be either clonic, jerk-like movements, or more tonic or dystonic. And sometimes can be quite complex. And here's a young girl with leg tics. The trunk and abdomen can be also involved. Often causing this truncal flexion or camptocormia or scoliosis as a result of these dystonic truncal tics. And then phonic tics, and I just wanted to share with you some examples of complex phonic tics, often manifested by coprolalia. This goes on essentially most of the day. You can imagine how stressful it is, not only for the patient, but for the parents and the family. Here's an example of a more stereotypic tic. This repetitive coordinated movement. Now this, you can see right now, this young man has essentially no tics while the examiner is in the room, but as soon as she exits the room, he manifests these complex tics. And the point of this video is that unless you actually videotape the patient without your presence in the room, you may not fully appreciate the spectrum of the tics. And when she returns to the room, he then consciously or subconsciously can suppress the tics.
You're having some tics, right?
So here's another phenomenon that we described about 5 or 6 years ago during my Stanford lecture in Sweden, that we now refer to as Lex stereotypy syndrome.
And what kind of tics do you have?
Just like stretching my neck out, like opening my mouth, I guess.
Random noises.
So in addition to the
been noticing
tics, you can notice these leg movements.
Since high school, I guess.
Okay.
I didn't really notice it before that.
And when do you notice it? When do you do
I'm sitting in class and I'll be doing it, like whoever's sitting next to me will tell me like just to stop.
Like, do you know why you're doing it, or
Just to calm me down, I guess.
calms you down? And how long have you been doing this in terms of moving your legs?
This is all the time. My leg is always, it's always rocking sideways. So,
Have you tried to stop it, or what does it make you feel?
well, I can. When I'm thinking about it, of course I can, make it stop.
So this is a leg stereotypy syndrome, probably the most common movement disorder, and we initially described it back in 2016 and more recently, a couple of years ago. So, so far we focused on the motor manifestations of Tourette syndrome, namely tics, but I think most of you recognize that Tourette syndrome is much more complex than that and is often associated with a variety of behavioral problems, including attention deficit with hyperactivity, obsessive compulsive disorder, and many other behavioral problems, including anxiety, depression, conduct, oppositional behavior, loss of impulse control, learning disorders, socially inappropriate and self-injurious behaviors, and many other behavioral and psychiatric symptoms. Just to sort of give you a picture of what Tourette looks like based on a large number of patients in this registry. We had 6,800 patients, and this registry was contributed not only by neurologists, but mostly psychiatrists. And you can see that the male to female ratio was 4.4 to 1. The mean age at onset of tics was 6.4 years. And the mean age of diagnosis was 13 years. So there's a long delay often in the diagnosis, which is now improving as a result of increased education by the Tourette Association of America, many other organizations, and Tourette is becoming also recognized in medical school, and so many physicians are now more familiar with Tourette syndrome, plus the information on the internet. In this registry, the family history was only present in 52% of the patients, but in most cases, family history is much more common, and I'll come back to genetics later on. But what I want to draw attention to from this particular Tourette International Consortium is that in among these close to 7,000 patients, 14.2% had just tics and nothing else. So the vast majority of the patients with Tourette syndrome have more than tics. They have tics plus attention deficit disorder, OCD, and variety of other behavioral problems. One of the best studies on the lifetime prevalence of these various behavioral and psychiatric comorbidities was published about 5 years ago. And in that study, they found that the overall lifetime prevalence of these psychiatric comorbidities was about 86%. And 72% of these individuals met the criteria for OCD or ADHD, but there were many other behavioral problems, including mood, anxiety disorders, and a variety of other behavioral problems. Now, as a result of the motor, behavioral, and psychiatric symptoms, many patients with Tourette syndrome, unfortunately, are compromised in school and at work. And this was highlighted by this study from a Swedish cohort, which included over 3,500 patients with Tourette syndrome. And what they found was that even though Tourette patients clearly do not have any abnormality in their intelligence, they have a substantial academic underachievement, largely because of the motor and behavioral compromise that may interfere with their academic performance. So noted that Capro phenomena is a typical feature of Tourette syndrome, but unfortunately in many cases it's overemphasized, and I've seen patients who were told by their pediatricians that they don't have Tourette syndrome because they are not shouting obscenities. It turns out that Capro phenomena is relatively uncommon, and in this study that we conducted with Dr. Friedman, we found that only 19% of males and about 15% of females have coprolalia, and copropraxia, or obscene gestures, are even less frequent. These occur usually 5 years after the onset of tics. So Capra phenomena certainly can occur in patients with Tourette syndrome, but it is not universally present. In fact, it's relatively uncommon. The kind of coprolalia that the patients with Tourette syndrome exhibit consist of uttering or swearing of obscenities rather than profanities, although, again, there's a rich expression of these obscene or profane vocalizations. In many cases, Tourette syndrome is considered as a benign disorder that is manifested chiefly by blinking or facial grimacing or sniffing. But unfortunately, in many cases, Tourette syndrome can be very, very troublesome and disabling. And we coined the term malignant Tourette syndrome to draw attention to this very disabling form of Tourette syndrome. In this series of 332 patients that were categorized as having malignant Tourette syndrome based on at least 2 emergency room visits or 1 hospitalization related to Tourette symptoms, 5.1% of our Tourette population, which is a referral population in a specialized center, qualified as having malignant Tourette syndrome. There are many reasons why Tourette syndrome can be very disabling or even life-threatening, particularly because of self-injurious behavior. For example, in this patient, he has the urge to bite his lower lip that had to be reattached. There are many examples of self-injurious behaviors like hematomas and abrasions. This young woman wanted to cut her throat to see what it would feel like. Here's another example of self-injurious behavior. Probably the most severe case I've seen is this young man with very severe Tourette syndrome and OCD who had a compulsion to eviscerate himself periodically as a result of the urge that he experienced. Unfortunately, after 18th or 19th attempt, he succumbed to this tic and died. So here's just a list of some of the self-injurious behaviors that we have encountered, including hitting the throat, causing impairment of breathing because of swelling of the larynx, spinal cord compression because of the whiplash tics, and many, many other examples of self-injurious behaviors that can be very troublesome and even life-threatening. I draw attention to this paper. It was just published on self-injurious behavior. In addition to Tourette syndrome, there are many, many neurologic conditions that can be associated with self-injurious behavior that is often very difficult to treat. This article reviews the phenomenology and treatment in some detail. So what is the natural history of Tourette syndrome? Typically, most children start with attention deficit or hyperactivity around the age of 4 or 5. This is then followed by the occurrence of motor tics, usually in a rostrocaudal progression, starting with blinking, facial grimacing, neck jerking, and other parts of the body being involved later on. Then phonic tics often start simple tics initially, such as sniffing, throat clearing, grunting, and this then evolves into more complex utterances, including coprolalia. And then obsessive compulsive behavior emerges usually shortly before puberty, and it's the type of comorbidity that often persists way beyond childhood into adulthood. Typically, there is an exacerbation of all of these symptoms, especially tics, just before puberty, around the age of 9 and 10. And then many patients do undergo remission, but I'll come back to that later. There have been only really 2 or 3 studies addressing the natural history of Tourette syndrome. One of the best studies is a study by Block and colleagues from the Yale Child Study Center, where they enrolled 46 children, followed them from a mean age of 11.4 to 19 years. And what they found was that tics were at their worst just before puberty, around the age of 10 or 11. But OCD increased subsequently, and again, peaked around the age of 14 or 15, but often persisted into adulthood. From the time 1 to time 2, which spanned about 8 years, about 1/3 of the patients underwent remission, but OCD often persisted and, in fact, increased. Another natural history study was published 3 years ago from the Danish National Tourette Clinic, where they followed patients for 6 years, and they found that at the end of this follow-up, only 17.7% above the age of 16 years had no tics. So the vast majority of the patients continued to have tics, and about 23% of the patients had actually moderate or severe tics. Again, there's a common misperception that tics are childhood disorders that eventually resolve, but that is not the case. Tics can persist into adulthood. And that is the reason why we conducted this review of 43 adult patients we had seen with Tourette syndrome, and noted that in these patients who have tics, both motor and phonic tics and other features of Tourette syndrome, about 81.4% of these adult tics were recurrences of childhood tics. Typically, these children undergo remission after adolescence, and they may be tic-free for years or decades. And then in the mid-40s or mid-50s, they have recurrence of their tics, and they often present to the clinic with adult onset tics. So the most common cause of adult tics actually are recurrences of childhood tics. Well, what is the prevalence of Tourette syndrome? This has been a subject of many, many studies, and Scharf and colleagues summarized 21 population-based prevalence studies and concluded that the overall prevalence of Tourette syndrome is about 0.52%. And again, it varies from one epidemiological study to another. The next question that everyone wants to know is what causes Tourette syndrome, and I wish I knew the answer to that. I will summarize very briefly what has been done in terms of research to better understand the pathogenesis and pathophysiology of Tourette syndrome. First, brain autopsies have been done, very, very few, probably less than a dozen, and they have been very non-revealing. They did not really show consistent pathological or biochemical change in these brains. I will review briefly structural neuroimaging, functional imaging, neurophysiological studies, genetics, and then see whether secondary tics may give us clues to the pathogenesis of Tourette syndrome. So in terms of imaging, there have been many, many studies. I just want to highlight a couple of these studies. This is a study of 24 children that had a fairly sophisticated MRI imaging. And in this particular study, no differences were found between patients with Tourette syndrome and controls in terms of gray and white matter. A year later, Molnar and colleagues published another study using 3 Tesla MRI, and they did find subtle but important differences between the patients and controls, particularly noting that patients with Tourette syndrome had lower depth and reduced thickness of gray matter compared to controls. That needs to be confirmed by other studies. We talked about this natural history study from the Yale Child Study Center. In addition to looking at clinical features, they also repeated MRI scans, and based on these imaging studies, they found inverse correlation between caudate volume and the presence of tics and OCD. So during this follow-up period, those individuals that had the smallest caudate volume had the highest risk for tics and OCD. So decreased caudate volume may correlate with the presence of Tourette symptoms. There have been many functional imaging studies, and again want to draw your attention to only 2 or 3. This is from David Adelberg's group, where they looked at fluorodeoxyglucose PET scans in 12 patients with Tourette and 12 healthy controls. And they found 2 patterns that differentiated Tourette patients from controls. One was increased in bilateral premotor cortices and cerebral activity, and decreased activity, metabolic activity in caudate, putamen, and orbitofrontal cortices. And those 2 patterns, they felt clearly differentiated between Tourette patients and controls. Now, for a long time, Tourette syndrome has been considered a hyperdopaminergic state because anti-dopaminergic drugs improve tics. But there's very little evidence to support this notion of hyperdopaminergic state. And this is illustrated by one of the best studies looking at striatal dihydrotetrabenazine and methylphenidate binding in Tourette syndrome using a PET scan. And what Roger Albin and his colleagues at the University of Michigan found was really that there was no difference in the striatal dopaminergic innervation based on these studies between patients with Tourette and controls. So at least that study could not provide evidence of hyperdopaminergic state in Tourette syndrome. On the other hand, looking at other neurotransmitters such as GABA, Mark Hallett's group at NIH found fairly striking differences between Tourette patients and controls. So using flumazenil as a GABA receptor ligand, they found decreased binding in the ventral striatum, thalamus, insula, and amygdala, and increased binding in the substantia nigra, periaqueductal gray, and other areas, including cerebellum, in patients with Tourette syndrome. So they concluded that the primary neurotransmitter defect in Tourette syndrome involves the GABAergic system, which leads to disinhibition, since GABA is an inhibitory neurotransmitter. Other studies, mostly from Dr. Hallett's group, drew attention to certain areas of the brain that might be involved not only in generation of tics, but also in the premonitory phenomena. And they specifically focused on the right dorsal anterior insula, which has high connectivity with the frontostriatal areas. And they concluded that the right dorsal anterior insula may be part of the urge-tic network and could influence the urge and tic-related corticostriatal thalamic regions. This is supported by another study published recently, again drawing attention to the abnormality in the insula based on the voxel-based morphometry. And they found abnormalities again in the posterior and the anterior insula, suggesting that one involves motor tics, the other involves the premonitory urge. And there is really no direct relationship between the two, although both of them might be due to a dysfunction of the insula. What about neurophysiological studies, such as looking at bright shaft potential? As you would imagine, patients with psychogenic or functional jerks have a robust bright shaft potential. But some patients with Tourette syndrome also have a bright side potential, as demonstrated in this study of patients with jerk movements. In this study, 6 out of 14 Tourette patients exhibited bright side potential prior to tics. Although this is not a consistent finding, at least these studies suggest that some of the tics may be mediated through voluntary pathways. What about the genetics of Tourette syndrome? I think everyone recognizes that genetics plays an important role in the pathogenesis of Tourette syndrome, but yet we have not discovered a gene or genes that cause Tourette syndrome. This is partly due to the phenomena of bilineal transmission that we highlighted in a paper published many years ago, where we pointed out that in a typical family, the child may have tics and both parents have some features of Tourette syndrome, such as father having tics that may or may not have persisted throughout adulthood, and the mother may have features of OCD, and both may have features of ADHD. So this is a typical nuclear family of a child with Tourette syndrome. So heritability is obviously increased in patients with Tourette syndrome, despite the lack of genetic findings. And many studies now have concluded that Tourette syndrome is a highly polygenic disorder where there are genetic risk factors, but not necessarily specific genes. So if nobody in the family has tics, the risk of having tics is about 1 to 2%. If a family member has tics, it's 10 to 17%. If there's a non-identical twin, that twin has a risk of 23% of having Tourette, and then identical twins have 77% chance of having tics. This is an updated slide from a review article we published in 2012, where we highlighted some of the genes that were at that time identified as possibly causative for Tourette syndrome. Since that time, there have been many other gene loci and genes identified as potential risk genes, but again, there's no single gene that has been identified as a cause of Tourette syndrome. What are some other clues that we can learn from studying other tic disorders besides Tourette syndrome? So we know that there are a number of genetic disorders such as Huntington disease, neuroacanthocytosis, and many other genetic disorders that can be manifested by tics. There are many drugs that can cause tics, including the dopamine receptor blocking drugs. Probably the most common cause of drug-induced tics is cocaine. There are many infectious or immunological disorders that have been associated with tics, carbon monoxide, and many other disorders have been associated with tics. Here's an example of somebody who I believe has secondary tic, 41-year-old man who was involved in a motorcycle accident, sustained injury to the left shoulder, and 2 weeks later developed these jerk-like movements that I think everyone would agree have the characteristics of a tic. There are many infectious, para-infectious, autoimmune disorders that have been associated with tics, and unfortunately we don't have time to discuss PANDAS or PANS, but I draw attention to this study was just published a couple of weeks ago, where the investigators found antibodies from children with PANDAS that bind specifically to striatal-cholinergic interneurons, again, providing some support for the autoimmune etiology in these patients who have PANDAS or PANS. Certainly, stress can also exacerbate or trigger tics, and during this period of COVID-19 pandemic, the children are often under stress, and this recent article drew attention to the fact that about half of the patients with Tourette syndrome during the pandemic had exacerbation of their tics. I just, again, want to draw attention to a very interesting phenomena that we have observed recently in teenage girls who developed a tic-like disorder after they watched a TikTok person named this trippy hippie on TikTok, and they developed what we refer to as mass hysteria, where they simulated her tics, and we had observed these girls recently. So this is a young woman who I think everyone would agree has tics involving mainly her shoulders and trunk. And
How old are you?
20.
I just want to illustrate the phenomenology.
Involuntary movements.
Since May of 2009.
Okay, so about 8 months or something like that. So you find that sometimes vibration can trigger these movements. So what I want to do is have a feeling for the apply to the neck and see if that will trigger some of these movements that will help us decide how to treat it. So here we go.
Yes, that works.
That really does make it worse. Okay,
so the application of the tuning fork triggered her tics, and she clearly has a functional psychogenic tic. Among the different psychogenic or functional movement disorders, tics are probably the least common, but we summarized our experience with psychogenic or functional tics in non-patients and pointed out that they represent less than 5% of our overall population, which is probably higher than in most populations because we are a tertiary referral center. But there were striking differences between the functional tics that we saw in these patients and tics that are seen in patients with Tourette syndrome, such as lack of premonitory sensation. These individuals, mostly young women, could not suppress the tics, and there was frequent coexistence with other functional psychogenic symptoms. And in contrast to Tourette syndrome, which is more frequently seen in males, functional psychogenic tics are much more frequently seen in females. Okay, I just want to say a few words about treatment. We could spend a great deal of time on that, but before we talk about it, I just want to highlight all the different features of Tourette syndrome that need to be considered when we consider treatment and treatment strategies for patients with Tourette syndrome. So the treatment has to be individualized, multidisciplinary, and integrative. There are many ways that one can assess the efficacy of any kind of therapeutic intervention, but by far we rely on clinical rating scales such as the Yale Global Tic Severity Scale, YGTSS, particularly the total tic severity component of the YGTSS, but there are many other clinical rating scales that are often employed in clinical trials of therapeutic intervention in Tourette syndrome. Let's start with behavioral therapies. This is one of the best studies on behavioral therapy, and it's a meta-analysis of other studies where they concluded that comprehensive behavioral intervention for tics, or CBIT, which also includes habit reversal training, very effective in the treatment of patients with tics, particularly mild to moderate tics, but usually are not terribly effective in patients who have very severe tics. In terms of medications, there are many medications that have been tested in patients with Tourette syndrome. Probably the most frequently used medications are clonidine and guanfacine, which are alpha agonists. I rarely ever use these medications. I don't find them typically effective, but they are often prescribed by pediatricians and primary care physicians in early stages of Tourette syndrome. Currently, there are only 3 drugs that are FDA approved for the treatment of Tourette syndrome: aripiprazole, pibuzad, and haloperidol. I rarely ever use these drugs for a variety of reasons. They are dopamine receptor blockers, and as such can cause tardive dyskinesia, metabolic syndrome, and a number of other side effects. I do use occasionally flufenazine, and until recently we have had a great deal of experience with flufenazine before we started to use dopamine depleters such as tetrabenazine, deutetrabenazine, and valbenazine. Topiramate is another drug that we frequently use. I'll say a few words about botulinum toxin and DBS. So this is from a study, which was a longitudinal observational study of 268 patients treated with flufenazine at a dose of about 3.2 milligrams over close to 3 years. And we showed that about 80% of the patients had a marked to moderate improvement. Fortunately, we had no cases of tardive dyskinesia, even though flufenazine certainly can cause tardive dyskinesia. The drug that is probably most frequently used in the class of dopamine receptor blocking drugs is aripiprazole. This is from the phase 3 study that led to the approval of aripiprazole in the treatment of Tourette syndrome, where the investigators found significant reduction in YGTSS TTS in patients randomized to aripiprazole versus placebo. Unfortunately, aripiprazole even though it's advertised as an atypical neuroleptic with a low risk of tardive dyskinesia, certainly can cause tardive dyskinesia, as shown in this paper that we published a few years ago. Because of the fear of tardive dyskinesia that is associated with the treatment of dopamine receptor blocking drugs and neuroleptics, we've been interested in a class of drugs called dopamine depleters, such as tetrabenazine. In 1979, I obtained an IND from the FDA to study tetrabenazine, but subsequently I studied other VMAT2 inhibitors. So these drugs act by blocking VMAT2, which is part of the presynaptic vesicle that transports dopamine from the presynaptic terminal into the vesicle and then releases the neurotransmitter dopamine into the synaptic cleft to activate the postsynaptic dopamine receptors. If one blocks the VMAT2, then dopamine cannot be taken up into the presynaptic vesicle and is metabolized by monoamine oxidase, resulting in presynaptic dopamine depletion. One of the main advantages of VMAT2 inhibitors is that they do not cause tardive dyskinesia. So here's a patient with fairly severe generalized tics before treatment with tetrabenazine, and you will see that with tetrabenazine there is a marked improvement in her tics. Now, tetrabenazine is not without side effects. It can cause a variety of side effects, including drowsiness and possibly depression and many other side effects. And because of that, a number of pharmaceutical companies have been interested in VMAT2 inhibitors that perhaps will have lower risk of side effects. One of them is deutetrabenazine, where this hydrogen is substituted with deuterium, and as a result of this carbon deuterium bond, there is a slowing of metabolism of this compounded deutetrabenazine, resulting in longer duration of effect. The initial study with deutetrabenazine and Tourette syndrome was an open label pilot study that we conducted and published a few years ago, and we clearly showed that patients with deutetrabenazine have significant improvement in motor and phonic tic, and the total tic score significantly improved during treatment and again increased during washout. This study led to 3 studies that have not yet been published in which we participated. One was a study of deutetrabenazine using flexible dose. Another was a study using fixed dose. And then these patients were rolled into an open label study where they were subsequently followed. So this first study called ARTIST-1 study, 119 patients with Tourette syndrome were randomized, and you can see that initially there was a significant reduction in the YGTS TTS score in patients randomized to tetrabenazine compared to placebo, but unfortunately some patients eventually returned to baseline. So this study unfortunately did not meet the primary endpoint, but there were many other secondary efficacy endpoints that did suggest efficacy of the drug. In the ARTIST-2 study, 158 participants were enrolled, and again, you can see that there's some improvement initially in patients randomized to deutetrabenazine, but unfortunately, that improvement was not sustained. And again, this study did not reach the primary endpoint, unfortunately. There are many explanations for this. I'll be happy to discuss it with any one of you individually once these studies are published. Another VMAT2 inhibitor, mainly valbenazine, has been studied in 3 trials in patients with Tourette syndrome. Unfortunately, all of these studies, again, did not reach the primary endpoint, although there were many secondary variables that were suggestive that valbenazine is effective in patients with Tourette syndrome. And there's an ongoing randomized withdrawal study. Unfortunately, none of these studies have yet been published. I just want to take a second to reflect on double-blind placebo-controlled studies, which are sort of the gold standards for evidence-based medicine. But there are many drugs that are clearly effective and safe, yet have not reached approval because the double-blind placebo-controlled studies were negative. And there are many papers that sort of reflect on some of the limitations of evidence-based medicine. I'll give you some references here, and also highlight this humorous article, but at the same time, important article suggesting that there has never been a double-blind study of parachutes since they clearly work. And even though we aspire to apply evidence-based medicine in our clinical practice, I submit to you that most of the patients who we treat with these various medications probably would not qualify for the studies that led to the approval of these drugs that we use. So even though double-blind placebo-controlled studies are important, one, I think, has to use common sense and experience when we decide which drugs or treatments are most appropriate. And this is illustrated by this real-world experience on VMAT2 inhibitors from our center, again, suggesting that the VMAT2 inhibitors are clearly effective in a variety of disorders, not just Tourette syndrome, but tardive dyskinesia, chorea associated with Huntington disease. And in fact, VMAT2 inhibitors have been approved for the treatment of tardive dyskinesia and chorea associated with Huntington disease. So there are many other approaches. We really haven't had a chance to discuss the other approaches in detail. We talked about the antipsychotic drugs. There are a couple of studies on the dopamine agonists, such as pergolide, pramipixole, suggesting that they may possibly be useful. We talked about aripiprazole and the alpha-2 agonists, and then the VMAT2 inhibitors. I just want to say a few words about a new class of drugs, namely D1 antagonists, blockers of the D1 receptors. This is taken from our initial study of ecopipam and D1 receptor antagonists, showing significant improvement in these children treated with ecopipam. And this result led to a study that is currently underway called Diamond Study, where we are looking at a large population of patients with Tourette syndrome and see whether this D1 antagonist, ecopipam, can be effective in the treatment of their tics. This is from a study we published some time ago showing that topiramate also can be quite effective in some patients with Tourette syndrome. There are many other treatments. If you ask young adults or even adolescents who use cannabis, who admit to you that they use marijuana, they often will say that of all the treatment they tried, marijuana is most effective treatment, and that has been studied in many centers. But in this review article on the therapeutic potential of cannabinoids, we concluded that cannabinoids are usually not terribly effective in most movement disorders, but they might possibly be useful in the treatment of tics. Another treatment is botulinum toxin injection, particularly in patients who have vocal motor focal tics. This is the only double-blind placebo-controlled study by Connie Maris involving 18 patients, showing that those patients randomized to botulinum toxin had a significant improvement in their tics and also in their premonitory urge. And there have been many other studies that are summarized in this review article showing that botulinum toxin can be a very effective treatment in patients with focal tics. This is especially true in patients with cervical tics, especially these whiplash tics. This is one of our patients who developed quadriplegia as a result of persistent whiplash tics, and fortunately with botulinum toxin injection into the neck extensors, the whiplash tics improved and he recovered from the quadriplegia. I will conclude with a few comments about surgery. Just about every part of the central nervous system has been treated or targeted either with ablative procedures or deep brain stimulation in the treatment of Tourette syndrome, particularly globus pallidus and thalamus. We've been focusing mainly on GPI in the treatment of Tourette syndrome with DBS. That also has been shown to be a useful target in other studies. This is taken from the International Tourette Syndrome Deep Brain Stimulation Public Registry of 185 patients. Two major targets were used in the study, GPI and central median thalamic region. They showed overall marked improvement from baseline in terms of YGTSS, and the overall adverse event rate was relatively low in this particular registry, about 35%. And DBS clearly is effective for phonic tics as well as motor tics, and particularly when targeting the central median PI. This is, again, a recent study showing different targets, again, mainly focusing on the GPI and central median nucleus of the thalamus, showing at least 40% improvement in tics. And there's another review article recently published from Muller-Wahl that I highlighted here. There are a number of targets that are currently being investigated in treatment of OCD without tics. So this is a video of our first patient that we treated with DBS. This is before surgery. So you can appreciate how disabling the tics are.
After about a month with the stimulator turned on and with various adjustments, you started noticing what? So
within a few weeks after DBS was turned on, he had marked improvement in his tics, and five years later, he continues to benefit from the GPR DBS. So I want to conclude with this slide that draws attention to the American Academy of Neurology practice guidelines, where we reviewed most of the evidence-based literature on the treatment of Tourette syndrome. And where we basically concluded that there was a high confidence for CBIT, but there was only moderate confidence in some of the other treatments and low confidence in these other treatments. Again, this was a review of mainly double-blind placebo-controlled studies. So studies that did not meet these strict criteria were not even considered. And the studies on VMAT2 inhibitors obviously were not included in this review. So this is an algorithm that we use in a diagnosis and treatment of patients with Tourette syndrome. Once we make a diagnosis of Tourette syndrome, we obviously try to educate the family about the various behavioral and motor aspects and provide as much information as we can. If the symptoms are not troublesome, that we just follow the patient. If the patient does have troublesome symptoms that interfere with activities at home, in school, or at work, then we consider behavioral therapy, pharmacotherapy, including the alpha-2 agonists, dopamine depleters, topiramate, and some of the dopamine receptor blockers, botulinum toxin, DBS, and try to also address some of the behavioral comorbidities. And if possible, try to enroll patients in experimental therapeutic trials. So despite the fact that Tourette patients may not have benefit from therapeutic interventions, and in some cases were not even treated, such as Mozart, many patients can contribute a great deal to mankind. And even though there's no definite proof that Mozart had Tourette syndrome, I think there's enough evidence that we reviewed in this article to suggest that he may have had some features of Tourette syndrome. And certainly Samuel Johnson clearly did have a variety of tics suggestive of Tourette syndrome. And despite any kind of treatment that clearly was not available at the time, he contributed a great deal to mankind. So I want to conclude just with sort of an advertisement of two books that have a lot of videos that I didn't have a chance to show. One was the Movement Disorder in Childhood book, and this other book that will be the third edition of the Aspen book that also has lots of videos of patients with Tourette syndrome and other movement disorders. So I hope you'll have a chance to come and visit us at Baylor College of Medicine. And we are located in this nice building in the middle of the Texas Medical Center, the world's largest medical center. So thank you for your attention, and you are welcome to reach out to me if you have any questions. Thank you very much.